So now we're going to really quickly whiz through our psychosocial and functional treatment. So this is what the evidence base says does work for chronic pain. So basically it's a change of diagnosis, so it necessitates a change in treatment. That makes sense, right? It's no longer an acute pathology, it's a system problem. Pain is no longer a symptom, it's a system problem. So chronic pain, it's painful, but it also leads to a whole host of problems in people's lives. And the problem with these problems is that they lead to more problems. And suddenly you no longer need pain for these problems to self-perpetuate. And the problem with all of these problems that are now self-perpetuating is that they all contribute to nervous system wind-up, so they amplify pain. So when people see a psychologist for pain, they think, there's a psychologist, everybody thinks I'm crazy. So we tell our patients, actually, psychology is not the study of crazy, psychology is the study of behaviour. And that chronic pain is not psychological, it's neurological, it's a nervous system problem, it's your nerves. And helping them understand that actually, because pain impacts so many areas of our lives and so much of our behaviour and so much of how we feel, psychologists are involved because behaviour is involved, being a human is involved, and what drives the way we behave and how we act is involved. So we come back to this lovely picture a lot, and it's the brain. And because the brain is basically the foundation of who we are and what we do. And pain is a protective system, and I want you to think of the brain as a protective system. And pain has been so useful for our survival that it is embedded throughout our entire being. It's all of the areas of the brain, and it's weaved throughout our entire body. There's lots of different controls all the way through our bodies for pain because it's been so good for our survival. And it's so good for our survival, it brings in things like emotion. I need an emotional response to pain because if I get sore, I need to cry out, I need to call my helpers, I need to withdraw so I can heal. If I feel a bit more tired when I've got pain, or if I feel sick, or if I feel sad and unmotivated, I'm not going to run around with my pain. That's really helpful. If I feel anxious about my pain, I'm going to do something about it. That's really helpful. If I feel angry when I've got pain, I might be more irritable. I might stop people from touching me when I'm in pain and making me worse. That can be really helpful. But it's not just the brain systems we're looking at, it's the fact that these underlying physiological things that are happening in our brains impact my thoughts, my feelings, but this will then impact my behaviour, but this works in reverse as well. If I do something, that impacts my thoughts, and that impacts that underlying neurophysiology. And what we often talk about with patients is those drugs that we're giving you, they work because of the natural endogenous opioid and cannabinoid, never say that word, systems within our bodies, okay? But there are things that we can do at these levels to activate those systems as well. So when people think, well, I'm going to do some hippy-dippy relaxation and therapy, people think, well, why is that helpful? And it's helpful because it's actually working at every layer of our being and every layer of that intricate, embedded system that is our pain system. So we're no longer looking at chronic pain like a switch we can turn off. It's this. It's a whole bunch of switches everywhere at every layer of our being and our function that we modulate rather than turn on or off. And this either amplifies pain or it can inhibit pain, okay? So this is this idea that actually there's a lot of control that we can have over pain. Not consciously, and I make that really clear. It's not something you've decided, oh, well, I'm going to have pain today or I'm not going to have pain today. It's unfortunately not that explicit. What's really, really interesting is actually loads of research has shown that quite unintuitively, it's not the amount of pain that we experience that predicts disability because of pain. It's not pain intensity that impacts our quality of life. It's in fact our response to pain. So if I'm fearful of my pain and I avoid doing things, that's where my quality of life is impacted. Okay? And we see this time and time again. So in the pain clinic, we're not looking to change your pain intensity if you come and see me. We're looking to improve your quality of life and reduce your suffering. Okay? I'm just going to flip through that. And this is the crux of what we're trying to do. So basically, if I experience pain and I interpret my pain to be something sinister or be something that I'm helpless in the face of and I can do nothing about, I'm going to be fearful, I'm going to be distressed, and that's going to lead me to do things to try and get rid of the pain, okay? So I'm trying to get rid of the pain. It's a bit like if I see a dog and I'm scared of dogs, what do? Do I just stand there quietly and wait for the dog to go? Do I run up to the dog happily and pat it? No, I run away. And then what happens? The dog chases me because it thinks it's a game. And then I become more fearful. And I learn over time to get rid of that horrible fear that I feel when I experience pain or I see a dog, that avoiding it is really helpful. Or if I'm really worried about it, I might focus on it a lot because I need to be really vigilant of it, because when it comes, I need to be able to jump on it and avoid it. Take my medications, lie down so I don't flare my pain up. And what we get then is disuse, we get depression, and we get disability. And the next time I get pain, not only do I have the fear of the initial pain and what that could mean, but also the previous experience of pain as being something that impacts my life really negatively. So then I don't like pain even more. So what we're trying to look at is how I interpret my pain. If I can approach my pain without all that baggage, without all that fear, then I can do things despite pain. And Lynn will talk soon about how we do it in a way so that our body doesn't further try and protect us by producing more pain. Through function, then I can confront the pain and I can recover, not necessarily in terms of my pain severity, but in my quality of life and the suffering that I experience alongside that. And this is where we want to talk to you guys about reassurance, because reassurance is this lovely thing that we do to try and make people feel better because they're distressed. But what do we know about reassurance and pain? How do we reassure our patients? We say, don't worry, there's nothing wrong, or I'll send you for a test and you'll see that there's nothing wrong with your body, or I will send you to see this specialist. And we know that actually the patient most patients actually don't feel relieved if if they've got chronic pain. They feel like, I don't understand, I don't know what's going on. Some patients do. Some patients have one test, they say there's nothing wrong and off they go. They're not the patients we're talking about here, because they're not problems for you in the settings that you see them. What we know is actually your patients will be happier with you if you send them for more scans, if you give them more pills, because they'll feel like you're listening to them and doing something to them. But actually what we know is that maintains that unhelpful biomedical focus on pain. That pain is the problem, not the way that we're approaching it. That pain relief is the aim that we need to be able to manage pain. And basically that's saying to them, if you can't get rid of your pain, you can't manage. And we want to flip that and say, you can have pain and still manage. And actually, paradoxically, we often find that once they're managing well, we do see pain reduction. Not always. And we see this with parents all the time. If that scary dog runs up to me and my mother picks me up or looks scared or tries to shelter me from it, the message she's actually giving me is, dogs are scary. You can't manage dogs. I need to protect you from this. So try and think about that when you think about what are the messages you're giving your patients when you're trying to reassure them about what's happening for them. If your patient continues to ask for scans or treatments or referrals, sometimes you just want to get them out of your office, and you can explain to you blue in the face that this isn't the way, la-di-da, and they're still going to be asking for them. But really you need to think, have I done everything that I feel like I have? Am I confident with my diagnosis of chronic pain? Have I discussed all the limitations of treatments, given them John's previous talk? That hasn't put them to sleep then. And have I sort of validated that diagnosis? And at that point, if you've done all those things and they're still asking for more, you need to think about a referral to another service who can manage what's actually really health anxiety or problems with distress tolerance and coping. It's that consistency of the message, though, from you that prevents them from staying in that unhelpful cycle. This is just, again, that consistency. So reassurance actually increases this idea of fear and hypervigilance, because why would my doctor send me for a scan or for a test if he didn't think something was wrong or could be wrong? Again. And this, I think, is a really helpful diagram, because if you see the pain interrupts our life and we worry about pain, if it's an acute problem, that's appropriate. Worry about it within that biomedical framework, My problem-solving behaviour will be go and try and sort out the pathology. And if that was the problem would be solved. But when the problem is unsolved, because actually chronic pain can't be treated effectively in a biomedical problem frame, I get stuck in this perseverance loop. That worry increases because I then become hypervigilant to that pain. What we need to do is shift them out of that loop and change that biomedical framework to a biopsychosocial framework. And that can actually be really difficult. So what are some strategies that we use? Well, we've talked about validation and education. We need to find out what their fears are. Think about those thoughts and behaviours that might be amplifying pain. Think about broader concurrent difficulties. If there's a lot of stress in somebody's life, it's going to be very hard to sort of manage some of their pain, but it's also going to be winding up their pain system. Empowering patients to have a voice for themselves. We're trying to change that locus of control and help them to develop some self-efficacy for the pain that they're experiencing. Really important. And those catastrophic thoughts, if they think that they've got endometriosis and that means that they're somehow defective or that they're infertile, that's a really unhelpful message. Help them by just talking to them, what do you think is happening in your body? And explain, well, actually, there's no relationship between that and that problem, or we can worry about that later, or that's not what's causing your pain. Secondary gain, I'll just touch on here. For most of the patients we see, secondary gain is not such an issue, but for some people, there's a lot of other stresses and difficulties in their life, and actually medical attention can be very validating. It can feel very safe. It can feel like they're being held. It can feel like somebody's listening to them. And so sometimes it's about thinking what other needs are being met for this patient through this pain, and thinking about how can we support more adaptive ways of meeting those needs. And for some patients, they've had this pain for 30 years. And for suddenly them understanding that they didn't need to be suffering with this pain for 30 years can be almost too much for them to manage, and they'll have to go through a massive period of grief, loss and adjustment. And some people are very defended against that and they're not even going to go there. And other people you'll need to sort of help counsel through it or refer to somebody who can. Flare-up management is probably a really important thing to think about in GP land or primary care, because actually lots of patients experience these big exacerbations of their normal pain. And if you think again of that protective brain, stresses and all these cumulative things can happen that actually trigger the body to protect more with pain, and so that can be a flare-up. It's really important that our patients realise that it's actually really normal, and even in the best case scenarios we really, really see patients who don't experience flare-ups at some times, and oftentimes we can figure out what those triggers are, and it can be where a pain diary can be quite useful, where you can see over a couple of weeks, oh actually every time I do this plus I have a stressful day plus such and such, I get a flare-up.
Just a question, sorry, with the chronic pain trajectory, do you ever see it sort of go back down to baseline?
Yes, yeah. Absolutely. Everyone's can be different. You can have some people who have no pain in between flare-ups. Yeah, it can be completely different. And some patients will promise and swear black and blue that their pain stays exactly the same all the time, and it's a 10.
But the fascinating thing is if you ask people, it'll often disappear for 2 hours in the afternoon, and they're watching TV at night, and it's 8 out of 10.
Yeah. So it can go right back to baseline. It's really important for them to not sort of list this as an acute on chronic pain problem, because again, if we're thinking about how we're interpreting chronic pain, it's not an acute problem, it's a chronic pain problem, and flare-ups have to be managed from that same framework of chronic pain and not an acute pathology. But yeah, that's where the pain diaries can be useful. And then I've got some flare-up plans that I'll just put out, and you can grab them if you want on the way out, and we've got loads of links to different flare-up plans that might be useful for you guys in our resources. But it's kind of a two-pronged approach. One is that we plan to avoid flare-ups where we can, and certainly we often can't avoid flare-ups completely, but we do reduce the frequency and severity of flare-ups and how long they sort of knock people back for. So we plan to avoid this by thinking about all the things that are contributing to pain and basically developing a nice sort of everyday pain management plan. And then also planning to manage when that flare-up happens. And a lot of that's around managing distress, managing the people around you when you're in pain, managing possibly the pain itself, but more oftentimes it's about sort of helping them get back to having a plan to getting back to good function once that flare-up sort of ceased. And so there's a lot of distress tolerance as well, because pain is distressing, it's supposed to be, and normalising the distress that people experience with pain is important as well. And again, it's really important to include primary supports, because if your patient is trying to re-engage in activity, and let's say vacuuming seems to be something that chronic pain is really difficult to do with, so we'll say, well, maybe you vacuum for 5 minutes and you sit down. So they vacuum for 5 minutes and then they sit down, and then the wife comes in and taps your head and just picks up the vacuum and finishes it for the patient. So that plan might have been really useful, but then it's being undermined by family. So making sure that it's communicated to the rest of the family is really important. And sometimes you'll need to support the patient to do that by having the family member sit in on a consultation. And really importantly, other health professionals.
Yeah, no, sorry, go ahead.
You go.
I just wanted to add that one of the problems we have in the pain clinic is when our patients have a flare-up and they'll call an ambulance or they'll go to the ED or something like that, and sometimes even before they get to the ED they've been given morphine or something like that from the ambulance staff. So one of the things that's really important, I guess, for us to be doing is educating healthcare professionals about flare-ups, and that helps with reducing that acute kind of approach to management. But also within the CDHV we have care plans that are on the computer system that the ED staff and others can access, and they'll say, what not to do as well as what's helpful. And so, yeah, it is about also managing awareness of flare-ups for healthcare professionals.
Yeah, and that's exactly what I was going to say there, my next point. Yes.
Can I ask, do they have their, do patients have their own care plans?
Yes.
Yeah.
So they can take it with them?
Yeah, they can, but some patients will take a completely different one than what's on the system.
Yeah.
So you do have to be a bit
They
careful.
often choose 11 o'clock on a Friday night to present, or they're actually pretty clever, some of these patients, of knowing when's the time to go into hospital. So, yeah.
Yeah.
It was nationwide, so if you presented to any
It would
It would be.
tap into their,
Yeah.
because I know in Tauranga we have the online care plans for them, so when they present it just brings up
Yes.
the care plan.
Yeah,
Yeah.
that's
But if
the
they went to
same.
Waikato,
Yeah.
they get more things.
That's where it is more difficult, yeah.
very
And we also have joint case conferences with ED, with women's, with paediatrics, all of those things. So making sure that you collaborate as much as possible, or as you can, with other health professionals. But yeah, those shared care plans are really helpful. And it might even just be asking, is this a flare-up of your normal pain? Yeah, and lots of patients will be like, oh yes it is actually, yeah, it's just worse. We are also really clear with patients though when to worry. So when should I worry? So if they have new symptoms, and we say, look, it could just be your chronic pain sort of manifesting in a different way, but you still need to get it checked out.
I think that's the difficulty is that if they do present and then they get thoroughly investigated because there's the thought that there is something new, so that's a real concern.
Yeah.
There's a new pathology.
Yeah.
But then once it's excluded and they've been given morphine and all, they've been given a whole host of things, then they kind of get handed over to us. And then
it's little that you can do.
You have to break the news to them that actually it is a flare, or it's a flare of something new because they've got a lot of yellow flags, or they've got some pre-existing risk factors, and then and because the teams are like, okay, right, they need to go home, and the patient's there basically reeling about, okay, it's nothing, I thought it was something horrific, or they do get laparoscopy, or they do get investigation.
So that's sort of often part of the care plan as well, saying if this patient presents, they do have chronic pain, and so actually if you are going to go through some of those things with them, it's often like you have a consultant come in who knows the patient already to come and do some of that stuff so that they sort of don't go through all the loops and jumps that a typical patient would go through. Is that
Well, if they've been admitted under multiple specialties as well, because then it becomes...
Yeah, and that's where that collaborative care plan, so that all those specialties are aware of that care plan. But again, you'll get people who they don't even look at the care plan.
Yeah.
So best laid plans, but I think the more that we use them and have them, the better people get at using them.
The other problem is the opposite, is feeling fobbed off, and our patients describe that a lot. So they'll turn up and they won't get over investigated, but they feel that they've been fobbed off. So I think it's really tricky to get the balance right, actually. I don't think it's easy.
And we do talk to our patients about how to talk about chronic pain with the ED teams so that they don't get fobbed off.
Yeah. So it's also empowering the patient, because the patients are pretty smart as well.
Yeah.
So they can sort of so we teach them to try and get that happy balance. But there's no easy solution to these problems. I mean, and you see, and especially when somebody's going to ED 60 times a year. But
especially if they haven't been seen in a chronic pain clinic. Do you know what I mean? So they're being managed in the community. Like you said before about under multiple specialties and investigated for, been to a rheumatologist, been to a neurologist, and been to all these people, and they themselves might not even know that that's.
So that's a good criteria.
Absolutely, and that's a good yellow flag for you guys to be sending them our way so
If
that
they
we
will
can
come.
get those.
Yeah,
And
if
that's
they'll
the,
come,
and
yeah,
that's
yeah.
the problem. that
But
you
certainly
refer.
limits can be put in around these services even if they won't
Yeah.
engage with us. In fact, they're more likely to engage if they feel like, or they often come because they feel like we're going to take away the limits to them getting opioids.
So
or
sometimes we do boundary plans, to the extent that one patient, our most famous patient, had a boundary because she was calling an ambulance every day. So the chief medical officer had to okay the ambulance because she was just creating so much havoc. But eventually she ended up in jail and then everything was solved.
But we do have patients who call ambulances, and then we work with St John's so that they don't get the drugs that they want without being taken to hospital, and they stop calling the ambulance because eventually, if they realise they're not going to get where they need to go, they don't.
So my understanding of care plan is like health professional focus. There is information for the health professional to what this patient. But does action plan work in this situation? Like, I mean, we have asthma action plan, we have breathlessness action plan, and this action plan.
We have three types of plans.
Right.
We have the end stage life plan, and then we have the acute care plan that we're talking about. It's called an acute care plan, even though it's for our chronic pain patients. And then we have a patient developed plan. So the acute care plan is probably the one you're talking about, and it's clinician led or clinician developed. They do work. One of the only issues we have with it is that it can be changed by multiple clinicians. So I guess it goes back to making sure all clinicians are on the same page with what is in there, including the acute services, the GP, and also often for us it's our team having involvement in that plan as well.
So what I mean is like the patient action plan. Like if they get a flare up.
Do
step one.
they work? Yes.
Yeah, they do work.
Yeah,
They
that's
do
what-
work.
That's what,
Yeah. Yeah.
That's the patient-orientated
That's-
care plan.
Yeah, they do work really well.
Yeah, they
And
do.
actually what we find is that as they start working, the patient develops greater self-efficacy
Yeah.
to manage the pain. They lose that fearfulness. They're not afraid to go and do things in case they have a flare-up. And that's where you really get that kick-off with quality of life improving.
If I sort of reassure them, oh, remember this happened before and it got better, so just remember that.
Yeah,
Yeah.
sometimes it's about reminding them.
A bit quicker,
Yeah.
because
Yeah.
they're thinking,
But
And
yeah,
sometimes-
flare-ups always end.
They're tracking along really well and they sort of forget about their flare-up managed
Yeah.
plan, and then they have a big flare-up and you say, well, did you use your plan? And they're like, no.
Because it's
I
been a
didn't."
long time since
Yeah.
the last one.
Yeah. So sometimes it's just about reminding them to use it.
It's hard to think clearly in a flare-up.
Yeah, it is, and that's because pain is focusing your threat on the threat. I mean, your attention on the threat as it's supposed to. So, these are some of the things that will amplify pain. If you think again about those different layers in that brain. And these are some of the things that will turn down the volume of pain, so encourage that descending inhibition of pain. And these are the things that we try to amplify in our psychosocial treatments. Now, Lynn is going to talk to you about.
So now onto a bit of a practical side of the doing, and just remembering that when people come to us, especially at tertiary level, we don't under sort of mind the fact that these people have often tried everything to the best of their knowledge. They've tried multiple exercise programs, often they've been to lots of different people, and for some reason it just hasn't got them to where they wanted to be, or it's worked for a wee while and then they've fallen off again. But the key thing about function is that if you want change to happen in the brain, you have to do it. You have to do stuff. So it's all very well having the information, but it's the doing that changes those pathways. And all the functional pieces are really underpinned by that cognitive work that we work as a team together on. So if someone's got fears and anxieties, obviously we need those to be addressed as part of it. But these are the key aims, and it's really about maximising function alongside pain, enhancing quality of life alongside pain, and really promoting confidence that I can manage to do things even though I've got pain. And increasing people's personal skills within that. So using every strategy we can think of to be more active. And you can see our immediate focus at that time is not on reducing pain, it's on reducing the suffering that comes with having chronic pain and being able to re-engage with life again. So just harking back to what Jess was talking about with pain-related fear is more disabling than pain itself. Of course, we have to really address those issues within being more active. So obviously we're really looking at where those barriers are, and fear, we've talked a lot about that. That's a huge piece. And remembering that also people have come in, they've experienced trying to do more many times, and it's led to more pain for them, or more disablement, or more avoidance. So they've got really strong patterns in their brain and their thinking and expectations of what is going to happen to them if they try and be more active. So people are often quite worried about what a physiotherapist will do, physiotherapy OT as well. We really looking at their confidence, as I said, and their beliefs, what they think will happen to them in future. So many people have this expectation of ending up in a wheelchair. That's really, really common, or just not being able to engage in life, or getting into old age with a normal sort of function pattern. And one of the really big pieces is we look at patterns of activity. So we have our buzzwords of boom and bust and pain contingent and avoidance. But all of us have ways that we operate, of things, ways that we go about things that work for us. And so a lot of these people have these patterns, particularly the boom and bust kind of pattern, before they even had pain. So that's where I feel good, I'm going to get the job done. But what happens is, if I've got a chronic pain problem, I will bust out somewhere. So I'll go for it. I'm having a good day. The sun is shining. I need to make the most of the opportunity while my pain is relatively okay, and I go for it. And then I spend 3 days in bed or not doing, or however that works. So it's this into it, out of it pattern all the time, and that's a really, really common pattern for people. And they see it as being useful because they get the job done, but it's the idea that it's not really changing anything, and it's constantly keeping you in this pain flare-up pattern. The avoidance, as I said, we've talked about, and pain contingency of the pain is choosing what I do each day. It's and all of those, the pain is making the choice. And a lot of people just do not know how to go about it. So some of the things we talk about feels like quite common sense to us, and people say, oh, that's common sense. But when they actually try to apply it, it's a lot harder. So a lot of people just haven't got any really idea of how to go about getting a job, getting tasks done, or re-engaging in life without being sore. And we've talked a lot about education, and the education starts right at the start of that pain journey. In the acute phase, if there is an acute phase, or in those early stages, it's the messages that we give to people. It's addressing those fears and those concerns, and really promoting the benefits of staying engaged with activity, asking people about what they value most, playing with their children, going to their workplace, engaging with their friends and social life, and addressing those fears about movement as soon as we can. And the reason I put these pictures up here is because so often I've sat in a clinic where I've had someone with chronic back pain, and I've been sitting there trying to sort of explain to them and educate them about the reasons why their back is solid and stable, and how it's okay for them to move, and there's no issue with doing damage. And behind me there's a picture of a spine with a dirty grey disc in red, and so there's a lot of implicit messages in our clinics that we're saying one thing, but it's not congruent with some of the other pieces around. So I would encourage you to have a look around, because some of these posters are quite catastrophic. Some of those anatomical posters with all the spine bits on them, really, they're good for our knowledge, but they're maybe not so good for our patients to see. So education underpins everything. People understanding why they're doing them. And these are the key messages. They're not just cliches. We've borrowed a lot of these from Butler and Mosley, who do all the explain pain research and work. But really encouraging people that, yes, you are sore. We know you're in pain. However, it's safe for you to be moving. In fact, the the benefits of moving far outweigh the benefit of staying still and avoiding, in terms of all the nourishing your joints and motionless lotion. We talk about that, nourishing your joints, feeding your circulation, and keeping your body working. And one of the really simple ones that I find a lot of our patients, particularly the younger ones, really kind of connect with is this idea is that your hardware is okay. It's actually the software, your nervous system, that needs a reboot. And the good news is that our brains are plastic. These things can change, and it's the doing that's going to change that.
We had a guy come through, and his analogy was, my plumbing's okay, but my wiring's misfiring. And for him, that really kind of made sense to him.
So, in a nutshell, this is what we do to help people reactivate. Really helping them understand how they operate, what activity patterns they're using. This booming and busting is just maintaining that flare up and that pain pattern. And in actual fact, we know that over time, if people keep going at it and then busting out and going at it and busting out, gradually, actually, it takes less and less to aggravate their pain. So, less doing and more resting, and then they gradually go into a bit of a decline. We talk about pacing, and a lot of people go, oh, I pace, I know how to pace, I've been taught pacing. And when we actually go into it, often it's what we call pain contingent. It's I stop when I get pain. I do what I can until the pain tells me not to. For us, that's not pacing. So things like trying to help them work out actually what their activity level, what they're capable of without booming and pushing into their pain and significantly increasing it. And setting a tolerance level on a baseline. And this is really boring for a lot of people. They don't like doing it because it takes a lot of persistence and patience. So what I mean is people actually experimenting. So if I said to you, how far can you walk? Most of our patients will overestimate, because they'll tell you what they can do on a good day, which might be once a week or once a month. But when you actually ask them to go for a walk 5 days in a row, they might be able to do 25 minutes one day and 2 minutes for the rest. So we try and get an average of that and then actually drop it down even more than that. And then a lot of people struggle with that because they're used to getting the job done. And when I say, well, only go for a 5-minute walk, and that's 2.5 minutes out and 2.5 minutes back each day, they're like, well, why bother? So really encouraging people that you've got to start somewhere, and it's not useful to keep pushing into the pain because you're just maintaining that aggravation, and really being patient and persistent. So when someone comes and says, well, that walking program or that exercise program or that activity program didn't work, often it's like, well, how long did you persist for? And did you go back to the drawing board? Were you staying with the plan? So those are quite important things to ask people if they are coming to you and saying, well, you know, I was giving it a go, but actually it didn't work. You've got to really persist for a long time to work these things through. And everything goes with, as I said, addressing other strategies that will help modulate the pain system, help wind things down. So it's not just getting active and going for it, it's about using every strategy you can to calm your system, and then gradually pacing up in a really slow, developed manner. And having a thought for flare-ups, having a plan, because we know that they will happen. And so we also look at, how do I get back to activity, and how quickly do I get back to activity if I have had a flare-up that's sort of knocked me back a wee bit. One of the things I haven't mentioned in there too is if people have really marked fear of particular specific activities, then we will often use a sort of a graded exposure program as well, which may include touch desensitisation as well as movement strategies, and often we'll do it combined with a clinical psychologist where we're both addressing those fears in the moment. So yeah, I can't really sort of push enough how slow the process has to be, but how once people get the idea of consistent movement and activity, actually then that's building confidence. And once they get the idea of that they're not constantly flaring them up, we're rewriting some patterns there. it works really, really well if people do it to the plan.
And once people get it in one sort of domain of life and really get it, then they can apply it much more broadly, so you start to see sort of the change becoming much faster.
Absolutely. And the other thing is that it's all goal focused, so it's not about what I decide the person's going to do. We negotiate that based on what they want to get back to doing, and it might be the activity management might be, as Jess said, 5 minutes of vacuuming, you know, along with some other pieces. If people have specific movement deficits, for example, we have people who might be doing just a general reactivation program, but they've got a stiff shoulder, then we'll also address something specific for that particular area. But we don't hugely focus on that. It's more about doing and re-engaging.
Oh. When you're increasing slowly, what sort of, are you going maybe like 10-20% up? Or
Yeah.
People are always like, oh, I walk for 5 minutes, tomorrow I'm going to walk for 10.
That's a really common problem. So one, we get people to write the plan, and so we get them to do experiments for the first week of whatever the activity is, and basically get them to write down how much they could do in a kind of a pain contingent manner. Then we basically add it all up, get an average, and then knock it down by about 20%. So they're starting with a lot less than what they think they can do. And then that's what they start with. And then when it's time to increase, which might be say after a week, they say 10 to 20%, but it depends on how fearful or how sensitive or how irritable or easily aggravated people are. So no more than 20%, but usually I'd go about 10%. And so it is slow, but after a while then that gradually increases. And
so in other words, doubling every day is not what we're talking about.
Yeah, absolutely not.
They realise until you tell them that they're
doubling,
that they're, you know,
Yeah.
5 minutes seems like nothing to them.
Absolutely.
So they go on, do 10.
Yeah.
And 20.
And that's why it's really good for people to actually write down what they do. Again, some people find that really tedious, but if you write it down, you can look back and go, oh, my plan was to do 5 minutes every day, but I actually did 10, 15, 20. You can see that, and then you can have that conversation around, well, what didn't work? We're back to the drawing board. If it doesn't work the first time, let's go back and look and try something again. And it's really, it's about the way you do it. You know, so a lot of people have done some really good exercise work and things, but they've boomed and busted, or they've just fallen off and haven't been able to get back into it. So it's how you go about things that's really important. That's what makes the changes. Now I'm going to totally change tack, and I just want to make a comment about this, because a lot of people who come to see us have lots of aids and adaptations, anything from a handy reacher to a parking permit to the mobility scooter that they saw an advert for on the wall of the local fish and chip shop and got someone to get it for them. And now I understand that, you know, like if you're working with the elderly population, many of these people have co-morbidities and they need these things, these sticks and things for other reasons. But what I want to say is that if you've got a patient who's coming to you and sort of saying, I need you to sign me off on getting a mobility permit, or I need, you know, they've got a brace on, and you're thinking, I don't recall them having that broken wrist in the last 6 weeks, you know, it would be useful maybe to just ask that person, well, what is that for? Because braces and aids can mean a lot of things to people. It's often a way of helping people to validate that they've got a pain problem because no one else can see it. It might be that they're fearful of someone knocking, touching them. A lot of people say that they're fearful of falling, but when you actually sort of delve into that more, well, when did you last fall? Have you actually fallen over? Have you actually hurt yourself? Sometimes it's actually more the fear of falling. As I said, you've got to explore that a bit more in certain population groups that a lot of you deal with. But if it's for pain alone, if it's for fear alone, then we need to address those issues. And so I'm not suggesting that every patient who comes in from now on you just whip it off them and go, that's it, mate. But, you know, you just have a think about, well, am I going to validate or support someone in having this? What's it for, and what are the pros and cons? And who are we responding to? Is it easier for me just to say yes and tick this off and get this person out of here? People are often really fearful and really distressed, and so they can be quite persuasive in getting things from all sorts of different sources. So really, is this going to support this person to be more active, and what's the risk there?
And what's the message that their aid is giving their brain?
Yeah. So that is the other thing is if we're supporting someone to have a neck collar, like we get a lot of people who have got neck collars, and there is nothing on an MRI that supports it, or nothing on any scans except for pain itself. But someone's given them a neck collar when they had a whiplash 10 years ago, but nobody thought about what's the exit plan. Yeah. So when and often if you go to an emergency place, I know someone the other day who got a pair of crutches, and they said, well, when do I bring them back? And they said, oh no, they're yours now. I was like, that's a good system, isn't it? So it's really about what's the exit plan. Like why has that person still got that? Why are they still using that? What message is it giving their brain? And really it can be a form of avoidance. And sometimes if we don't ask that question and don't delve a bit deeper, then we're promoting this identity of a sickness role. And as I said, often you'll just see it escalate. And before you know it, and sometimes it's things like if you refer to a community occupational therapist, if they're not working in the context of a chronic pain management piece or a physiotherapist, and you say, I want this person to have a stick because they're falling over, then that's what they'll get. But if you think, well, they're falling over a lot, or they say they're falling over a lot, it might be best to send them to a falls assessment team to look at what the actual problem is. So it's just really being mindful of what we're promoting here and what we're supporting, and what are the patient's expectations. This is a wrist splint that you have for 12 weeks because you've just broken your wrist. After that, we need this thing moving, So and promoting those messages and being really aware of those implicit messages, signs on the wall in our practices. When you go out of here tomorrow, go back to work and have a look at what's around that might be promoting messages that aren't congruent with what you want to promote. It's you, I think.
Is that me?
It is you.
So there was a person last week in the pain clinic that had a moon boot on for 15 months.
So, what can you do? Educate, inform, validate. What are their fears? What are their beliefs? And also, what are the things around them that are promoting those fears and beliefs? So things like the use of aids, their family messages, the messages they've got from other specialists, limiting those external and passive strategies. So anything that somebody is doing to them is not going to improve their efficacy to manage pain themselves. So they're not going to have the confidence to manage pain themselves. Place boundaries around that reassurance seeking, and have a flare-up plan, and where necessary have an ED plan or a care plan. I've put some flare-up plans. There's a setback plan, there's like a everyday things I can do to manage plan, and there's like a tick list of pain management skills. I've only got 15 of each though, so if maybe there's not enough, we can photocopy some more, but we can send you links for them all anyway. And this is the pain toolkit. Who's seen the pain toolkit? A few of you. Pete Moore was this fellow from the UK, was he? And he had chronic pain for ages and was stuck in that biomedical framework for a long time. And eventually, 8 years. And eventually he found the right help. And he was like, why didn't I get this help 8 years ago? So he developed this pain toolkit. It's free to download. It comes in a whole bunch of different languages. There's some online things. It just says www.paintoolkit.org. So if you just type pain toolkit into your browser, it'll come up. And it's basically pain management in a nutshell.